p.m. and we're scheduled to start at 2, but I do not see Dana on the call yet, and she is going to be facilitating today's presentation. Most of you probably are aware that the state offices in Northern Nevada are closed due to the inclement weather, and so Erica will not be joining us today. And I am joining from home, so I apologize if there's any glitches. But if we could just give it another moment to allow more people to join and allow Dana to get logged on. Thank you so much. Hi, everybody. It's Monica with Nevada Health Authority. A couple of you have joined since I gave an earlier message. The state offices in Northern Nevada are closed today, so Erica's unable to join us, and I'm joining from home. So I won't be on camera, but I can see the chat and join via audio. And we are just waiting for Dana to join us as she is facilitating today's presentation. So if you could just give us a moment, I would appreciate it. But welcome to everybody. Okay, I'm going to stop sharing my screen for just a moment. Dina's having trouble getting logged in, and I'm going to try and get her into the meeting. I appreciate everyone's patience. Yay, there you are.
Yikes, I'm so sorry.
It's
I'm your
okay, and
presenter.
I did not
Okay.
see your
It went like,
message that you were having
yeah,
trouble.
it says registers don't need, or presenters don't need to register, but then it never had a link. It's
Oh my
stressful.
goodness.
I'm sorry.
Okay, so let me get your. All right, so let me start again. Thank you, everybody, for your patience with us. Again, this is Monica Schiffer with Nevada Health Authority. Erica is not with us today. The Northern Nevada State offices are closed because we're getting a pretty good dousing of snow, and we wanted to stay safe and keep the streets clear. But this is our monthly multidisciplinary information session for school health services. And today our presentation is on plan of care documentation. And our presenter is our one and only Dana Robinson, who is a licensed clinical social worker at the UNR PBIS TA Center. Dana, I think you probably know everybody, but if you want to introduce yourself before you get started, and if you just say next slide, I'll go ahead and manage your slides for you.
Okay, sweet. Thank you. Yeah, I know everybody on this call, and I'm kind of feeling for you all because most of you have seen this presentation. So hopefully it elicits some discussion around actual implementation of plans of care in schools and what that looks like. But my name's Dana Robinson. I typically am pretty tech savvy. I'm not sure what happened to me this afternoon, so I'm really sorry I'm late. And I honor your time together. I know you're all crazy busy. Um, I am trained child and adolescent therapist, and have worked across settings, in the last 15 or 18 years as a clinician. And in the last couple of years have only really been focused on school health, creating the most effective treatment settings or settings for mental wellness for students and families, which often occurs in schools. And so I've done a ton of talking to all of you and to your teams around developing referral pathways, developing plans of care that progress monitor effective treatment. And I really believe in that. So I believe that treatment works. And so it's pretty fun to talk through plans of care. Next slide, please. Then we can go to the next one. I think it's just the intro one. I'm gonna do two screens so I can see you. Yep. Okay. So what I really hope to do today, and I do think it is more laid back. So definitely come off mute and ask questions or put it in the chat. I want to identify components of an effective plan of care, and then I'm going to share. You'll see in the slide deck, which will go up on the school health website, or I can send to you. I did include a ton of examples of effective plans of care that are very school specific because it's nice to have resources. So we go next slide. The components of an effective plan of care. And so that's the next slide. Lots of good slides. So at the most basic level, it's sort of just a written pathway for us to do with a student and a family um, on what our goals together, our objectives and goals for treatment. I think one of the best things you can do when creating a plan of care is to lead with hope. There's a lot of research on that, which is actually pretty fascinating if you like evidence-based interventions. There's a lot of research that the provider, your therapist, hope within the setting is the most indicative of change. So I think if you are developing a plan of care and you sort of feel hopeless in the beginning, you're like, well, it's not going to work. This student's in a doozy. You lead with that. So if you come very hopeful of like, I hear what's happening and I feel very confident we can fix it together. Uh, that outpaces any sort of evidence-based intervention you do, which is kind of fascinating. So in your plan of care, you're going to have components that are standardized in any plan of care, not just your hope. So that was sort of like a tangent. You're going to have the presenting issue. So however the student came in for, and in Nevada, we do use a diagnosis. And so we can talk more through that too. we have a Project Echo coming about diagnosing within mental health within schools and what that could look like, that doesn't trigger a child find or an IEP. So kind of what that looks like. So oftentimes it's the symptoms of that diagnosis. So if you had a diagnosis of anxiety, your presenting issues would be the symptoms like I can't sleep, I'm losing friends because I am withdrawing from them, I'm having a hard time with my relationships with my parents. You're going to take the symptoms and have this as a presenting concern. And then the goals would be really to get back to a normal level of functioning, like we want to make it so that you can sleep, so that you can engage with friendship groups, that exercise feels normal. So you lay out the goals, and under each goal, there are objectives. So exactly how we're going to get to that goal. And then within a plan of care, you want to talk about the timing, the frequency. How often am I going to meet you? How often are you going to do these objectives? Like how often will you practice these grounding skills that we're learning together? I think it's also really important that a treatment plan is very collaborative in nature, and we don't always get to do that. Sometimes you run back to your desk and quickly write up a treatment plan, but inherently it's collaborative. Like you're going to practice these skills that I've taught you, and I'm going to teach you skills that will work. And if they're not working, will try something new. We'll do something different together. So it's an agreement we make together that you as a student are going to try some things, you as the family are going to try some things, and then I'm going to introduce you some new ideas and ways to do it. And the interventions are very specific. What's neat about interventions is that we know a lot about maladaptive functioning, and we know ways to treat that. And so there's tons of cool interventions, cognitive behavior interventions for trauma in schools, acceptance and commitment therapy, trauma focused CBT. I love motivational interviewing, which is like really like aligning with the student and moving along. But it's important that in that plan of care, you're also saying we're going to continually assess if it's working, because it may not. We try our best, and if in 30, 60 days the symptoms aren't improving, we're going to try something else. But we're going to do this together. So it's this collaborative sort of planning. I didn't see the chat, so I don't know if anybody has anything to say or any wondering so far.
Nothing so far.
Nope. Okay. We'll go to the next part. So there's these components, and if you'll go to the next slide, they must include SMART goals. And so SMART goals, I can see all your cute little names on here, so you know this, but they're specific. Like, what exactly are we going to do? I don't want to say, like, generally speaking, you're never going to be depressed again. Not really realistic. It's measurable. How are we going to know that what we're doing? We're going to take screenings. We're going to do self-report. We're going to do a self-inventory of, am I feeling better? Attainable is something that's very near and dear to my heart, because as a clinician, you'll be assessing their capacity for change, their, like lots of things play into that. Do they have a supportive family at home? Are they eating, right? Sometimes we make the dumbest goals about inner dialogue when they haven't eaten breakfast. So you're constantly, as the provider, assessing, is this a attainable goal for them, or is it too high? Or is it too low? Like I basically said, you're going to come say hi to me every day. We could improve a little bit on that. Is it realistic? So is it something that they can do? Like, sometimes we're like, go to the gym. Maybe they couldn't afford the gym. So maybe we could say, let's do 5 jumping jacks every morning when we get up. Like, think of realistic, attainable goals, and then time framed. Like, one thing, I'm talking really fast, so I'm trying to slow down a little bit. One thing that happens in schools is we have sort of this open-ended, like, you can go see Dana whenever you want, and maybe we're engaging in some plan of care, but it's kind of lackadaisical. It's like, man, I'm teaching you some things. That is not fair. It's not fair to the student. It's not fair to the provider we know with a lot of research that providers who have caseloads that never turn over, that sort of stay the stagnant caseload, then you get burnout. So it's good for provider well-being and for student well-being is like, we're going to do this for 6 to 8 weeks. And at 6 weeks, we're going to reassess. Is this working? Is it not working? What can we do differently? And maybe we'll need to go on longer. Maybe we met all your goals and you're doing really good. But we have a time that we're looking at for. It's not like you can always, I mean, you could always kind of come back, but you're not always in with Miss Dana. Pretty funny to call myself that. What I basically want to say is that I believe you will feel better, right? And I have some tools to teach you to feel better, and we're going to try it. And then within these goals, so ideally, there are tons of like resources that have examples of SMART goals written for you, so you wouldn't really have to do it. You can just say like, these are the symptoms Christy's talking about. I'm going to do these ones. And then your EHR or your documentation system would queue that up. Like, hey, here are the symptoms that we noticed, and here are some evidence-based interventions. And if you do this for 6 weeks, this intervention, there should be marked improvement, self-reported improvement. If you go to the next slide, I think it will give us some examples of a SMART goal. Yeah. Oh, this is another part that I really love. And so if we're following sort of this golden thread of clinical intervention, before I ever even got to a plan of care, I did an assessment with the family and the student, and I talked about domains of functioning. How are you functioning at home? How are you functioning in school? Um, where um, where is it hard? Like, where's the rub? But also, what are you good at? Because if I can assess for strength, I can write a really beautiful plan of care, because I could take a strength that you have and I could tie it into a clinical intervention. So maybe one strength is I'm very good at drawing. I feel really good about that. And so we can tie that into a plan of care. And even better if you can get the student or family to identify their own strength. Sometimes you can't, we all know those little guys that are like, I'm not good at anything. My little Eeyores. I'm bad. Everything's bad. Just terrible at it. And it takes a bit. But if you can get them to identify the strengths, it's even better, because then they're like, have something we can build upon. Um, and like, so a SMART goal wouldn't be, I'm going to reduce your anxiety or I'm going to reduce your depression. It very specifically says, it says client, but it means student will reduce anxiety symptoms by learning and practicing 3 numbered relaxation techniques daily, grounding techniques, resulting in a 50% reduction in reported daily anxiety. This is super important. Anxiety will not ever go away. And you should never have that in your plan. There will 100% not feel any anxiety. Some anxiety is wonderful. That's what keeps us alive. That's what keeps people going to work, mothering well. A little bit of anxiety, going to the gym is good for us. So you're not saying things that are crazy, like unrealistic. 50% reduction in daily anxiety is pretty good. It's getting to a place where I'm showing up at school and feeling better about myself. So within 8 weeks, we're going to look for a 50% reduction, and we're measuring this with a screening tool of anxieties, the GAD-7. So that's a really cool technique too, is to have the student and the family, there's other family screeners, but they could sort of self-assess of like what's been happening at home. But the student, before your weekly sessions, can take a screener and say like, oh, I'm feeling all right this week. I can measure myself from the last time I saw Dana to now, and I'm noticing a little bit of improvement. What's super important in this component too is that I think we clearly say who's responsible, because sometimes there is like this idea, and I think I even feel like this too sometimes. If you go to therapy, you're going to get the magical wand treatment and you'll feel better, right? The therapist is like Oprah Winfrey. You get a minivan and you feel remarkably better. But it is good to initially, at the first time you meet together, have a discussion of responsibility of like, I know what I can teach you and what I can show you, and you know your best way to learn. So you can talk to me about that. We can talk about that together. But it will be also your job to try these things out. And maybe some of the things I teach you are weird and you don't like them, but we're going to try them together. And if they're too weird, we'll try something else. So I think the next slide moves on to discharge planning. For Discharge planning should happen at the very beginning. Like when you're doing a psychosocial assessment, you should talk about like how will we know that our time is done together? And 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 how will you know you're feeling better? A lot of times it's kind of fun to revisit the original sort of notes, like, man, you were referred by your friends who said you're really sad and depressed and not sleeping well, and you're kind of stinky, you're not showering. And then we go back to him like, that's not true about you anymore, right? Ashley or whatever, you showered today, you smell really good, you're coming in smiling, you're going to be in the play, you're sharing your artwork. All uh, all these cool little pieces have sort of come together, and you're feeling a lot more whole and well. Um, so it's appropriate when the student has met all the treatment goals. So we know we're done. That's why you have some goals together. We know that we're done when you've met the goals that we set. 50% of the time, the anxiety has decreased. You have a toolbox of grounding skills or relaxation skills that work very effectively for you. Sometimes you can, well, this is what I hope in a lot of cases, sometimes you have met criteria for a diagnosis or potentially a diagnosis or rule out, and those symptoms have improved over time. And so you no longer meet the diagnosis for a generalized anxiety disorder. So we're not treating it anymore. That's a great way to end too. That also would show that you met all your treatment goals. Every once in a while, there will be like, we're not making progress together. And it can be that we never created a good like form relationship together. It could be lots of other factors. It's hard for you to come. Oftentimes with cute little high schoolers, things at your house are really not changing. And the family dynamic really needs some further help. So maybe we would refer into the community, or it's really worsened. The symptoms have really worsened, and so we need to do a more higher level intervention, maybe assess for medication management, all components that I would still do a discharge plan. And of course, the family and student can always discontinue. I think that is part of informed consent, is that you're not being forced into therapy. You can come or not if you don't want to. I think. And then I think it's really important whenever you can, um, encourage the student to be a part of like the discharge planning initially, but also to share if they successfully completed. So there'll be in schools, there's a lot of other people rooting for you. The school nurse may know, the school counselor. So whenever they're comfortable, if they could share their success, like, hey, I met all my goals, I'm feeling so much better. That is a really good, useful tool for discharge planning. I think next slide. These are the resources. So these are all my like favorite ones. A treatment plan with 30 examples, 30 school specific examples, and then evidence-based therapy for children. The Maryland Behavioral Health online training, I know you guys have so much time, but it's beautifully done and free to school-based providers. So if you're like wanting just some more tools in your therapy tool bag, those are really good resources. And I'm trying to think. I think it's just questions now, if you have questions. And I don't know, I'm getting random pop-ups.
I don't
But
see
then,
anything in the
yeah,
chat,
I probably
dear.
went
This
really
is
fast. So.
Monica. But it looks like somebody is typing. So
Okay.
I might give it a minute and see if anybody has any comments, um, or any questions, any scenarios that they'd like to talk through. So Nancy K says, thank you. Does a 504, which is an accommodation plan, come under a plan of care?
Oh, my friend. It's a whole thing of debate. So in some states, yes, and in Nevada, hypothetically, a 504 plan would count as a plan of care. I've been talking mostly from a behavioral health perspective, which is not accommodations, it's interventions. And so it's specifically designed interventions based on a deficit. So based on something or a diagnosis that is causing suffering for somebody. So it's not accommodations. It's very clearly like, I'm going to teach you an evidence-based skill and you're going to practice it. And I'm teaching it from a place of knowledge. Where accommodations oftentimes is like, how can we make this setting more comfortable or bearable for you? And so in my mind, it's different, but I know it has come up over and over in Nevada. And so I do think it sort of falls on how the plan of care or how the 504 is written. If it's it doesn't meet Chapter 2800's guidelines for plan of care. Is there hope for rehabilitation? That often is a question that comes up. Ideally, all plans of care operate under the assumption that the student's rehabilitated, meaning they can get back to a state of functioning, of healthy, however they define it, healthy functioning. I don't know if we answered it. Yeah. Totally. And in other states, so Monica's saying yes, like if it meets the requirements in Chapter 2800, then yeah. And other states totally bill for it. This presentation is definitely skewed towards behavioral health, which is mental and substance use diagnosing and treatment planning.
Do you see the chat now, Dana?
Yeah.
Okay.
This is so helpful. Just like another pitch. So Project Echo starts this week and it is around the most common diagnoses in schools. So if you have providers who, I'm trying to think, see your cute little names on here. If you have providers in schools who are like, I don't want to diagnose, I don't want to write a plan of care, I'm really kind of worried about all these things, definitely let's do Project Echo. We can hop on a call together and kind of talk through it. You want to have a plan of care. Like you want to have, you don't want to be just basically it sort of cheapens your profession in that I'm just meeting with somebody. I'm not actually using my skills to teach them something to make life easier for them. So you want to have a plan of care. You want to help the student feel better, and you want to show how you're going to do it. Aaron, Brie, yeah, Naomi, all the cute little Humboldt, Elko, Nye. You already have, all of you have heard some of these stories. Lion, sorry. Well, that's all I had, but I feel like a lot of
This
you
is
heard it
Monica. I
already.
will say I am not clinical, but I have been working in this space for a minute, and I really appreciated the fact that you talked about that a plan of care should be, I mean, a discharge plan should be something that is discussed and at the beginning. And I appreciate that just from, layman's point of view that, yeah, what will that look like? What does success look like for us as we travel down this path? So I'm going to say I got that little nugget. So thank you.
Yeah. Yeah, I love that piece. It matters from the beginning if I say this is hopeful. Hey, Tammy.
Hey, I just had a question. Get my hand up. Do you have like a template or some sort? I know you talked about examples, but some sort of a template for a plan of care of like what that would look like and maybe some check boxes or something for our people.
Yeah. Yeah, I do for sure. It's in one of my Google. It will take me a bit to find it, but I do for sure and can share that out. And really, like, ideally, your EHR should do it. I mean, and I know BHWorks is working on like it has check boxes, but working on SMART goals embedded based on a diagnosis. But really, that's what should happen. It should be fairly easy. Like your provider would be like, I see anxiety symptoms. These are the symptoms, and then it would queue up a list of like SMART goals. But yeah, I do have things like that, just to kind of like some guidelines. The Wiley treatment planners is a really nice too. So you could just
And
kind of flip through it and write it.
your slide deck, do we have access to it? Because at the last page you had, I think it was the last page, had like resources, like clickable resources.
Yeah, it does. Here, I have it in a Google.
But you
And
can't click on, the shared screen. Doesn't work.
Yeah, I do.
Tammy,
I
this
could put
is
it in the
Monica.
chat.
Erica
Hi,
will
Monica.
put the recording and the all of the attachments onto the School Health Services webpage when she gets
Oh,
back.
perfect. Okay,
And I
so you don't have to
it
worry
like
about it, Dana.
That's okay. It's real. I had it up to like in case I forget, because I talk too fast and forget stuff.
Thank you.
Yeah, and we can always no, a behavioral plan of care does not require an OPR, Karen. Yeah, and there is a code. There's a code you could use for plan of care reassessment and CASI, which is done every 90 days in Nevada. I think it's H002, but I have to check, so don't quote me on that. But I can send that to you too. So you would do, typically you do an assessment, a biopsychosocial assessment, and then the plan of care. And if you're lucky, you can do that all in one time, but you can't really. So you give yourself 30 days to get this plan of care done. So the next meeting can use another CPT code for a plan of care development. And then not at 90 days, you need to reassess. Technically, you probably can keep a plan of care for a year, but at 90 days is best practice. And then you would also redo a CASI at 90 days. So there's a code for it, which I just can't remember off the top of my head, but I can email it to you all. Yeah, Karen, I'm learning every day too, so don't worry. I'm glad you're asking questions.
Yeah, Karen, this is Monica. Same. I'm right there with you every day.
Yeah, the 90 days is specific to behavioral health. And really, that's how we're training in schools too, because ideally, we want to get pretty far in your plan of care by 90 days. Your school's only in session, I don't even know, it's not very much, honestly, out of the year. So, yeah,
generally
90 days.
180.
Right, yeah. So we got, if anything, this will encourage the provider around effective treatment, right? Like, I'm not going to say that you're going to be with me forever and ever. Oh, Carly, I know. Yeah, I know what you're thinking. So we could get and maybe we can together if you want to, we can get a lot more detailed as you grow your school health systems. So plans of care often will prescribe allied care, like a community health worker work or basic skills training. And so once your team is pretty solid on plans of care and you want to expand some of your codes or some of your service delivery, we can definitely get together and do that if you want to. Yeah, thanks, Monica. 180 days. So really, definitely you should be assessing. You're moving quick in schools for several reasons. There's not very many of you and a ton of needed students, so your caseload's rolling quick. And also, we are collaborative care model in that you would use out community-based services as needed too. It's weird just looking at myself because you're all off camera, so I feel like I'm staring at my hair in weird ways. Thanks, Monica.
Monica's going to join you.
Moral
We're getting
support.
pounded with snow up
Now
here.
someone else to look at. Thanks,
There's
Tammy.
Tammy too.
I'm making eye contact with myself, which I think is diagnosable. I need a plan of care.
Stop. Oh, shucks.
Anything else you guys are wondering about? No. Well, I hope
I
you're all
don't see
safe.
any hands or any other notes in the chat, Tina.
Okay. Well, you can call me or email me. I'd do this talk anytime you want.
Nancy is typing.
Nancy. Yeah, thank you, Nancy. Cheerleading team. Thank you, Karen.
Yeah, I appreciate you
Oh, yeah,
too,
too.
Dana. This is Monica, and I honestly, I am just I get really excited with the participation and everybody supporting what we're trying to do in the state with our kiddos. So I'll just take a moment to say thank you all for consistently showing up and helping us to move these things forward.
Yeah, me too. I'm excited about it.
All right. Well, it looks like everybody's taking off, so we'll give you some time back. Again, we appreciate all of your time. Erica will have this uploaded to our School Health Services Access Center probably by the end of the week. And if you have any questions or need anything, don't hesitate to reach out to us. Thank you so much, Dana, and sorry you had trouble getting in.
Oh God, I'm sorry. I'm glad you all stayed. Thank you.
Bye, everybody.
Bye.